Hey, good morning. This is Dr. Stephen W. Stites, Chief Medical Officer at the University of Kansas Health System, broadcasting live with you from the Dolph Simons Jr. Family Broadcast Studio. Welcome back to Open Mics with Dr. Stites. Today we have several great guests, good friends, joining us to talk about how changes in telemedicine coverage could impact this service that has grown exponentially during the pandemic. Telehealth is proving to help patients keep their appointments and stay safer and healthier. But provisions around the coverage of these visits, that is, how we get reimbursed for that and how things will get paid for around it, are set to expire unless legislators take action. Dr. Keith Sale, the Vice President of Ambulatory, and Jason Grundstrom, Executive Director of the Continuum of Care, that's a lot of words. These are two folks who do a lot of telehealth and know a lot about it, are here to explain what that means to patients. We're going to get to that in just a few minutes. But first, Doc Hawk, it feels like we have hit a plateau in our rate of infections. Certainly lower, but kind of holding steady.
Yeah, no, I think that's good. I think we've seen that in national trends. We know that the KC Star article, I think from yesterday, showing our trends have also showed that it is decreasing. So I think that's good news, and I think that's even more impetus for us to overall as a community jump on the vaccination. So because we know that there are holiday seasons coming up, people will be gathering. This is now the time. If you haven't before, please get vaccinated now to help prevent another wave. And luckily, we haven't seen any rise of any new variants. So right now we're only dealing with Delta. I think that's another good thing. I think there's should be a lot of optimism from here on out. However, that optimism with the caveat of we need to continue to get a lot of people vaccinated, and especially that large population that are not yet eligible. And that is those children. Once they are eligible, please get them vaccinated. Again, to keep them in school, keep them healthy, keep them from spreading it to others that are at risk as well.
So, Hawkeye, truth or fiction, there's a breaking story in the internet now that the failure to find microchips in cars is because they are all in the vaccine. Truth or fiction?
Yeah, that'll be fiction.
Okay, so if I go to the North Pole with microchips from vaccine, I won't get stuck there forever because of the magnetic polarization.
Correct, you will not.
Okay, so America. Rest easy. There are not microchips in the vaccine. There's also not stuff that your body can't break down. In fact, within the vaccination itself, the materials that you get vaccinated with, how long do they stay in your body?
Oh, very, very short.
Like minutes, I think,
hours,
right?
yep.
Yeah, and then not long at all. And just remember that if you've ever had a colonoscopy and had to take lightly, that's got a whole lot of polyethylene glycol in it. Anytime you take a dose of Miralax, that gets more common as you get older, by the way. The Miralax, that polyethylene glycol is the active ingredient. It tends to be an ingredient to help stabilize mRNA in the vaccine. We take it all the time. It is not some terrible foreign substance.
Yeah, and again, these the amount of this substance is extremely small, minutely small. You probably ingest more of those substances if you look at the ingredients of things that you eat every day. So again, overall, just extremely small amounts of this. These substances, otherwise inert, really don't hurt you, but they can protect you. The vaccine does protect you.
The interesting thing is that people talk about messenger RNA vaccines there being such brand new science, and yet if you stand back and look at it, we've been having them out here since MERS and SARS, right? Because those vaccinations were developed in response to those infections, and that was like over a decade ago.
Yeah, the technology's been around for 30 to 40 years. I mean, this has been a 30 or 40 year overnight success story, really. And I think we just
that. Let's say that again. 30 or 40 year overnight success story. Yeah. I think that's approximately a very long time.
And just multiple people and multiple researchers adding their input and information to this to then collectively get to where we have right now. And we are still looking now forward to creating more mRNA vaccines, and I think it will be good overall for people's health around the world.
So I'm not going to become a nanobot because I took the vaccine.
No, actually the government has been tracking you, and companies have been tracking you.
They're very
for
afraid.
Decades
Be very afraid.
through your cell phone, but yet people continue to be on their cell phone 24 hours a day. So.
Yeah, I do tend to get on my cell phone, ESPN forever, and of course Star Trek.
Yeah.
All right, so let's see first if there's any reporter questions out there, since we've clearly dispelled all the mythology around vaccines right now.
And then I'll give the numbers.
Please do. Oh, I didn't have you give the numbers. Give the numbers.
I know. Well, we got in such a good talk of
the
overall cases are going down.
We were riffing.
Our numbers here at the health system, we have 17 active infections with only one of those people fully vaccinated. that person is in the ICU. We do have 7 in the ICU and 5 on the ventilator, and then 31 in that recovery period as well. And again, I think it just goes to the continued tragedy of this, and we know that these things are so preventable. This illness, this severe illness, especially if you're young. I had a patient yesterday in late 30s, unvaccinated, now on ECMO and on the ventilator and on pressor medications to keep their blood pressure up, and it just was 100% preventable.
Yeah, and that's the sad part is you don't have to die from COVID-19. All you have to do is get a vaccine, and it's like a 99.5% chance of not dying from dying from COVID-19. Just to say, yesterday the FDA did not act on a booster shot for Moderna, instead deferring that to one of their advisory committees, which turns out to be the same thing they did with the Pfizer vaccination. Thoughts about that?
Yeah, was able to talk with Kevin Alt, our local vaccine expert, and we know that ACIP will be meeting here in the next few days to look at the data, look at the recommendations. We didn't talk about what we think will happen, but you and I have talked about that, and we're just speculating, but I believe that it will probably be the same recommendations as for Pfizer. Again, more for keeping it simple for the general population. But also we know that especially for those older age groups, 65 and above, it will be recommended. So, but again, that's just speculation, and I don't know if you had any other thoughts.
Well, one of the things they said is that they didn't have that huge of a boost from their antibody levels when they got the booster. And remember, the booster in the Moderna is a half a dose. But the other point to be made is that Moderna's antibody levels tend to be higher at 6 months than Pfizer's, probably because it's a 4-week dosing interval versus 3. And they think, well, that's not a big deal. But actually, in immunology, that is a pretty big deal. Yeah. And it's a higher dose of the messenger RNA. So the people are still pretty highly protected at 6 months on Moderna. So if you don't need a booster then, I think you may still need one, but I just don't know the timing of it. So I'm curious to see what the FDA Advisory Committee and the CDC Advisory Committee all recommend about this question.
Yeah, and I know that we have seen published data out there in the public, but they will also have access to unpublished data as well. And what that published data continues to show is that anybody who got the vaccine even back in December and January continues to have great protection against hospitalization, severe disease, and death. So everybody who got Johnson & Johnson and Moderna, hold tight. You are still very well protected, and we should have some news here in the next probably week to 10 days, I would assume.
I think that's right. And I think the J&J one's going to turn out to have a booster because the J&J vaccine only is a one-shot regimen, and they came out with some data that showed a pretty big boost with that second dose after 2 months. So I think that's what's going to happen with J&J, somewhere around there. And I think we'll probably end up there with something around there with the Moderna
And again,
vaccine.
That's going to be good, too, because now you've allowed your immune system to evolve and develop from that first dose, just as you talked about the dosing regimens being spread out. This will be the same thing, and so hopefully that will add to more evolution of that immune response as well.
Yeah, that's so important because we all want to live long and prosper, which means make sure you get vaccinated. V for vaccination. All right, let's turn now to our guest for just a moment. Let's get into a little bit of a deep conversation about telemedicine and health because we know it's a really big deal. We know that there's especially a large impact on those who are living in more rural areas, and that 15% of America are who live in rural areas are some of our oldest and sickest patients. Man, that access can be especially difficult. You have to go a long way to get care. Guys, talk to us about the impact of telemedicine and what it means on healthcare today.
Well, I think, Steve, I'll be honest, when I was first going into telehealth during the beginning parts of the pandemic, I was skeptical, like a lot of our colleagues were, right? Having not used it before, I think ultimately we had concerns about, okay, can I really accomplish what I want to accomplish with my patients? And it turns out it has been a boon for us in healthcare. I think we've been able to connect with our patients, both near and far. We've been able to maintain chronic healthcare conditions and patients' healthcare despite not being able to see them in person on a consistent basis. And so, to be honest, I think it's actually been a big step forward in adding another avenue of care for our patients as we start to try and maintain things after the pandemic.
So I want to tell you, I had my first telemedicine visit. Okay, it was a long time ago because I was a physician, but the real pioneer here at KU years ago, a little shout out to Gary Doolittle. Gary is one of our outstanding oncologists. He practices especially in the world of sarcoma and some other things, and a good friend and a great leader here. So Gary was doing telehealth, and we had this room set up back in the corner of the internal medicine clinic. This was a long time ago. And you had like walls of equipment. You guys can't see our studio here, but there's this big wall of equipment that really does look like the bridge of the Enterprise. And that's kind of what it looked like. You'd have all this technology in this room. You hit the button. We had cables wired all the way to Hayes, Kansas, where he was doing a cancer outreach clinic, and they had all this technology and stuff like that. You'd hit the button, and you just think, okay, I pray God, please make it work, please make it work. And sometimes it worked. Yeah. And Gary actually published a lot. We were a national leader in telemedicine back then. And today, I do a telemedicine visit on my phone, and my patients have their phone. Jason, that's come a long way on the backside there.
Yeah, it's phenomenal. You're exactly right. Not only do we not need cables, but we don't need restrictions currently right now of where patients are located. We can see them virtually anywhere.
No, well, wait a minute. What do you mean currently right now? Because that just makes sense. Why shouldn't I not be able to see a patient wherever they are?
Well, you're right. Technologically, we can see patients anywhere. But for the law that we have in place right now, we have some restrictions that are coming in place here soon. That before COVID-19 we had in place, and then there was some relaxation. But we have some threats that might bring us back to pre-pandemic.
Which would be really bad, including part of that is how insurance covers it, how folks pay for it. Talk to us a little bit about what's going on around that.
Yeah, so we have three major payer in what we pay attention to, obviously the federal government, state, and then private insurance. And so when we look at how do they pay and when do they pay, prior to the pandemic, we had to look at them individually. We actually still have to look at them individually, but most of them are following kind of the same guidance. And so prior to the pandemic, federal really set the kind of the restrictions that pretty much everyone followed. We know that coming up here soon, the federal waivers are ending. In fact, they're ending next week, and if the federal government doesn't change those things, the law actually states that when it ends, which is kind of around October 18th, they have to the end of the year and all those waivers go away. So it's very important from a federal standpoint that by January 1, we know where we are with the federal waivers in place. State's a little different. So every 30 days, the state has to update their state waivers for if they're going to pay for telehealth or not. And then private insurers, we have to look at every one of them. Some of them have been following the federal guidelines. Some of them have been making up their own. Because we have no laws in the state of Kansas which tell insurers, private insurers, how to pay for telehealth. So it's a moving target with all of them. We just know that we're looking really to the federal government, who then kind of all the others follow suit. So October 18th is a very important date. We haven't gotten any information right now if the federal government is going to move. If they do, they move every 90 days. And that would bring us into February, which is a really good thing because the law right now states that when they make a waiver and when the waiver goes away, they have until the end of that calendar year for those restrictions to then rescind. So if it ends in February, that's fine. We have actually until the end of 2022 for which we then have to kind of go back on figuring out what are we going to do with at least Medicare patients. Again, Medicaid state, moving target every 30 days. And then we are constantly talking to all of the private insurers. What are you doing? How are you changing these things? And again, those are individual conversations. But we know they pretty much follow what federal government does. So, as of right now, we're looking at October 18th, and then we will know better by then what we need to do by January 1. So no one's making any comments out, so we don't know, and we want to encourage all of our legislators to please extend those waivers because there isn't any legislation that's in place. I've looked at a federal level. There are 4 telehealth bills that have been presented. None of them have been debated. None of them have been voted on. So again, we're still beholden to these 90-day waivers. Same thing with the state. We know that the state of Kansas has been talking about introducing legislation at a state level. Haven't seen anything introduced yet. I think they're still talking about it. So again, they're still just moving that goalpost every 30 days as we are hopeful that some permanency to both at a federal level and a state level. Now at a state level, we're really encouraging them to also tell our private insurers what to do. Many other states do that. That's not uncommon. And so we're hoping language gets in there for our private insurers to also take up the mantle of paying for telehealth.
Yeah, that's a big deal, right? Because if we don't have payment for telehealth, it's going to crumble. And yet, if I look in the future, I can't imagine a future without telehealth.
Steve, it's, as I mentioned before, telehealth is, as a surgeon in my practice, you'd think, okay, well, how do you do telehealth, right? How do you see patients?
Surgery across that? Go ahead.
Pardon me?
You can't do surgery across telehealth.
No, not so much.
Not yet.
But I do have patients who require long-term medical management. I have post-op visits. I have a lot of patients where this really fits their needs, to be able to do a visit over their phone, over their computer, and not have to come into the office, whether it be because they come from a distance or because they have a busy work-life balance at home and just coming into the office is a challenge. A lot of those patients would just as soon cancel or reschedule or push their care out, and now telehealth gives them the chance to actually have that care when they want it and when they need it, as opposed to when it fits their schedule, in terms of being able to come in. I think a lot of patients in this particular situation really struggle when they can't get in to see us to maintain their care. I think we have a lot of chronic care conditions, and there's a lot of good research out there, whether it be chronic healthcare conditions or pulmonary conditions, that actually show some long-term benefits from being able to maintain that connectivity with their physicians. And by losing telehealth, you lose that extra avenue of care if we can't continue to provide that.
Yeah, that's a big deal. And so talk to us, how many visits do we do a day now with telehealth?
So we're right now around 600 to 700 visits a day. I think at our peak, we were around 1,400 a day.
Yeah.
So we still do a lot of telehealth. I think our patients and our physicians have both become really comfortable with the technology, and both now have found ways to help it sustain both chronic care condition management as well as acute care conditions.
Yeah. So talk to us a bit. What's down the road? Because I think pretty soon your phone's going to have all your information. All right, I'll be able to hold it here. I'll get an ultrasound of my heart. I'll be able to get an EKG for my heart. I'm going to listen to people's lungs. Tell me what do you see in the future?
You see, what I worry about is I think about your plane tickets, right? So I don't know if you remember a time. You probably remember a time. I'm not sure if everybody does, but there was a time when you actually had to go to the airport to buy a plane ticket.
Thanks for that. Yes,
right?
I do remember
and
that.
So, right, and I unfortunately I do too. But we're at a time now where you can buy that on the internet, right? And instant access off your phone through an app, right? That's what telehealth has done for healthcare. And by having this go away, having pay parity go away, having restrictions placed on geography again, all of a sudden now it's like I have to go back to the airport to get my plane ticket. That's a big challenge for patients, I think. And so I think in the future, it's only moving forward. I think we've started to scratch the surface around the benefits of healthcare with the addition of telehealth. It's not a full replacement strategy for in-person visits, but it's an adjunct to healthcare. And I think if we don't allow this to continue to develop over time, we miss out on a tremendous opportunity to improve the overall healthcare of our population and our communities. And I think we take a big step backwards.
So there's a study published in the Rockville, Maryland Agency for Healthcare Research and Quality that finds telemedicine is helping monitor chronic conditions such as heart disease and respiratory or breathing problems. It says that it's outcomes such as death, quality of life, reductions in hospital admissions. Is this true, guys, for what we're seeing in Kansas and Missouri?
I think it is, Steve. I think, through the Care Collaborative and other parts of our organization, where we started with telehealth very early on and began to lay the foundation for the healthcare benefits of telehealth, I think it has proven itself in that small patient cohort. I think as we've expanded telehealth across a larger segment of the population, we've seen those benefits expand as well. I think it's really important that we continue those. I know, Jason, if you have comments on that from your perspective.
Yeah, that's a really great point. We watch the benefits of seeing a patient, catching early issues, and being able to stave off some things that would have caused a patient to come into the emergency department otherwise. And so monitoring patients remotely, we've actually caught some early things. And then also just going back to the normal traditional video visits, having that patient be able to see their patient, keep their appointment. Dr. Sale was saying earlier that patients' appointments are kept. When we meet that patient where they are, at the time that's most convenient for them, they aren't canceling those appointments. They aren't letting that problem get worse, which allows us to see that patient, do an early intervention, and prevents them from coming into our emergency department later on.
So can this work for kids as well as adults?
Absolutely, yes.
Yeah, and we've done it with children as well. I think done it really successfully. One of the things I find when I do telehealth is that I miss examining the patient, I sort of miss being in the room with them, but I've also gained a little bit more knowledge about where they live, how they live, and I learn different things, and I think both things can really be good. And I especially think for people in rural areas who may have difficulty with transportation, that this is a really big deal. And you think about the 20-somethings and the millennials and Gen X. I think people are going to come into medical office buildings less, so they're going to want to have this at convenience more. What do you guys think?
So I think convenience is a big factor for a lot of patients, and I think there's multiple things that play into that. I think one is just doing it on your time, right, and when you're available and when it fits into your work schedule, your family schedule, your kids' sports schedule, right? There's a lot of things out there in life that tend to interrupt our healthcare, and a lot of us tend to put our healthcare at the bottom of the list. Telehealth allows us to push that up to the top of the list for a lot of patients. The other thing that's important is there are a lot of other reasons why visits get canceled, whether it's weather, whether it's a sudden change in family member situation across the country and you have to fly somewhere to go take care of them, that changes what you can do face to face. And so I think we're able to now overcome a lot of those subtle barriers that, as Jason mentioned, result in last-minute cancellations or no-shows and allow patients to continue to connect with their care teams.
Yeah, it makes a difference, I think. And so, Jason, is there emerging evidence out there that suggests this can help lower the cost of care in any way?
Yeah, when you look at lowering the cost of care, I think we miss how we monitor or measure lowering the cost of care. So let's take it from two different groups, right? So let's look at the patient first. It's not uncommon for our patients here to come and drive hours to our health system. And so lowering the cost of care from driving, spending money on gas, taking time off from work, finding childcare, all of that is a cost that we can say, well, I paid for that. Additionally, we can say that being able to do early interventions with our patients, we can actually say, for every dollar that you spend seeing your primary care physician and catching something there, you've saved $7. That patient has saved $7 from going into the emergency department. So there's a tremendous savings in time and resources on the patient side. Additionally, when you look at the provider side, there are less cancellations for patients and physicians need to see their patients, and in general, physicians are able to see more patients. And so there's a lot of what we call savings on both time and actually material dollars.
Yeah, that's got to be a really big deal. So what can our viewers do to help get their legislators and things like that? How can they help kind of express their opinion out there to tell people we got to keep this service?
Well, I would hope that everyone knows who their legislator is. If not, Google it. You can find out who they are. Their phone numbers are published in conversations. Talk about how great it is. I think a lot of us I've experienced telehealth. I've actually seen my physician twice now via telehealth. I know how great it is. I have wonderful stories of patients who have used it and have had great interactions with their providers. I'm having conversations with our legislators, and I hope that everyone can do the same thing too. So I encourage you, this is not something that's permanent right now. I don't want to go back to what it was before COVID-19. Where all those waivers came in place. And I think,
we'd like to get rid of COVID-19. We just don't want to get rid of telehealth.
I'm sorry, yes, I didn't mean to say it that way.
Let's be careful how you say that.
Yeah, no, I don't want to go back to the way it was before COVID-19 where we had restrictions in place that prevented a lot and discouraged a lot of telehealth encounters, which we have grown to love and kind of expect now with where we are in this kind of telehealth era.
But Keith, you and I talked the other day. The cost of a telehealth visit is actually not less than to the health system than the cost of a regular visit. That seems funny, but let's talk a little bit about that.
Sure. When you think about what goes into a healthcare visit, right, whether it is the registration and check-in process, whether it is the physician visit and time discussing the plan of care, or whether it's the nursing time around coordination of care or patient education, all of those things still exist with a telehealth visit. They don't just magically disappear because you're over video. All of those other components that surround the patient with their healthcare experience are still present and still take time and effort to complete. The use of video facilitates convenience and connection, but it doesn't necessarily remove the need to continue to do all the extra work that goes into patient care and helping make sure the outcomes are optimal for our patients.
So maybe there's a little bit of a physical structure you don't have for that particular visit. Although you still have to have one to see patients, but in person. But Jason, why is it that insurance companies want to cut the cost of these telemedicine visits so much?
That's a question I've been scratching my head on. It's interesting is probably all of you who have private insurance have been getting letters in the mail from their own telehealth programs. So we know that the program is effective. We know that they value it as well. So I don't quite know why they're trying to save money other than the fact that they're trying to save money. So I don't know that answer. I'm sorry.
Yeah, it's a hard one because healthcare as a whole has a pretty narrow margin. All right, you think about what our operating margin is, around 3% most of the time, and it's not like when you go out to a lot of other places where the margins are a lot higher. So we're not trying to gouge people for this. We're just trying to get paid for the cost of a visit, I think.
I think so, but I think there are some companies and organizations out there, though, who provide telehealth services on a skeleton crew, right? They have a doctor who is in another part of the country who gets on for a 5-minute visit, and that's all they do. There is no surrounding care. There is no extra care that goes into it. There is a big difference between those kind of services and the services that we provide as traditional healthcare providers. Yeah. There is no difference in my practice, whether I see you over video or whether I see you in person. The care that surrounds that is the same. Yes. But there are a lot of other services that don't do that.
I would argue it's harder on telemedicine because you don't have the person right there where you can talk to them eye to eye. It's different. Maybe someday we'll get really good at it. But right now, when we do a telemedicine visit with a patient, I think there's actually more follow-up. It's actually a harder follow-up. You have to work harder to coordinate the care than you do when you're in the room and everybody can just see and talk to them. It is a different deal. And for those of us in chronic disease management, which is what I do, then it is, it's still a challenge out there.
I think we're learning, right?
Yeah.
I think if you go back to what telehealth was like pre-pandemic, it was a challenge, and it was definitely very difficult.
It was hard, yeah.
We have made tremendous strides, and I think for this if this goes away, like I said, it will set us backwards, again, and will really hinder our ability to develop.
And it will cost care more. I mean, at the end of the day, if we can make sure people stay healthier in their homes, wherever they are, and they don't have to travel back and forth and lose time for their job, etc., this makes so much sense that the answer is the way forward, not the way backward, I think.
Agree 100%.
All right, Jess, let's see what questions we have out there. I'm going to guess there are a couple. Some of them might even be about COVID-19, but it's just a thought.
Yes, we've got a little of both. Okay, so this one's on topic. Mary is asking, is telehealth an option to prevent treatment delays caused by having to wait for COVID test results to get those appointments inside the office?
What do you think?
I think absolutely. I think you can hop on a telehealth urgent care visit and you don't have that restriction of please don't come into the office when you have a cough or a fever or are actively ill. You can do that over video and start to work through the process around what else could be going on besides COVID. Because although COVID is one of the more prominent healthcare conditions in the media right now, it's not the only healthcare condition that exists. People are still getting things like the flu and other complications from their existing diseases that need to be managed. And so I think an online telehealth virtual care visit through urgent care, through your primary care physician, through your specialty physician, all are great ways to kind of circumvent that need for in-person visits that require you to be otherwise relatively healthy.
Quick left turn and a pit stop. Hawkeye, influenza is real, and it's coming back this year. We're already seeing more than we saw almost all of last year.
Yeah, we know that certainly with the Southern Hemisphere data, there wasn't much. We do have concerns this year because of the unmasking, no mandates, meeting more, gathering more, probably this year than we did last year. So it is a very big concern. We are still encouraging everybody to get the vaccine for influenza. You can get both influenza vaccine as well as COVID-19 vaccines at the same visit. That is safe, so go ahead and do that.
Yeah, so I think we want to do it. We know there's been some cases already in our area and around the country, so let's make sure you get your influenza vaccination.
And I think when the pandemic first hit, we were at the end of our influenza season, so there were a few published cases about co-infection with influenza and COVID-19, but we really didn't see a lot of that. I think we do have that concern this year.
Yeah, and you don't want because you don't want the twin-demic, as we were saying last year, because we're cool. Jess, what else?
Ruth Ellen just has a comment. She says she absolutely loves telehealth. She supports it. She's able to keep seeing her arthritis specialist here at the health system because of telehealth. So that's good to know. One of our YouTube viewers, Jerry, says, I wonder how these telehealth visits will affect the VA.
Well, the VA, I think, has really helped pioneer some of this stuff in telehealth. I think they're ahead of the curve, right, Jason?
They absolutely are. They've been doing telehealth for quite some time. Yes. So I think I don't know if I don't speak too much with the VA, but I do know that we have some physicians here who actually see patients at the VA and use telehealth.
Yeah, they've been doing it for a while. And if you think about it, too, you think about somebody who's sick at home and doesn't feel good, and then they come into an office and you're like, okay, really, is that smart? You can make everybody else in the office sick. I mean, that's the perfect example for doing telemedicine, right? I mean, there's just so many good ways to think about that. Or you have a hard time getting around, you're not very mobile, but you need to have your heart failure checkup. A lot of this we can do on telemedicine more convenient for patients and really for the team.
Yeah, I think, one group I didn't touch on before was those folks who have challenges with getting around. It's not just that they can't physically get here, although rides are an issue for a lot of our patients as well. Just physically getting here, waiting on a ride can be a challenge for a lot of patients. But then when they get here, getting around, whether it's because they're in a wheelchair or because they have mobility issues for other reasons, can be a big challenge to get around a big health system or even your local primary care doctor's office. And so being able to do that face-to-face visit via a video device, whether it's your phone or your computer, can make it a lot easier for patients, for sure.
And you know what else? You don't have to find a place to park. That's like the best.
Very true.
Very true, Jess.
Carla has a question, and you kind of touched on it, but maybe you could expand on it again. Isn't telehealth not so great in the fact that people are not having vitals checked and doctors can't get that, see the body language? There's a little bit lost in translation. So can you just elaborate again how you're kind of finding your way around that part of it?
I would say, Jay, I think there is sometimes a little lost in some of that translation. There is something I like being in at least for my type of patients. And again, I do CF. It's chronic disease management. People are chronically, critically all the time.
Yeah.
But Hawk, when you're an ID clinic, how well does it work?
Well, you need physical exam for your lungs, obviously. Same thing in ID. We do some routine follow-ups, so maybe patients that leave the hospital on IV antibiotics and can be seen in that sense with the virtual visits. Otherwise, for a lot of new patients, we do like to use in-person visits so that we can do that comprehensive physical exam. So I think it really matters and depends on what the reason that patient is being seen for. Is it a new patient? Is it a follow-up patient? So there are those details there. But some things can, and for a lot of us, physical exam is extremely important in a lot of different specialties in medicine.
So, but I think we've gotten better at some of this stuff in telemedicine, and Keith. And for example, I know that sometimes my CF patients will come and say, "I have a rash," and it's like, "Well, do you have to come in and be seen?" Just get your camera, get focused. Let's take a look at that rash in your skin. I've done throat exams with patients with their camera on their phone. So I mean, there are things you can do. We're learning to adapt.
Yep.
Yeah, it's interesting. There's actually a lot of great technologies out there. I think, as you mentioned, we're on the very beginning of our journey with telehealth still. I think a lot of our patients can actually take some of their own vitals at home. They have home blood pressure cuffs. They can take a thermometer and check their temperature. There are things we can do to get that information from our patients. There are also devices now that let you do exams for people at home or in other locations. So I saw a patient the other day who was in prison currently, but who they had technology where I could actually look into their ear canal, I could look up into their nose, look into their throat over video, and see that there were no nasal polyps or their tonsils were normal in appearance. So all of that technology is up and coming, and I think we have to continue to develop that and improve that access. So I think, yes, there are some concerns about how effective telehealth can be in some situations. As you heard Hawkeye mention, not every patient is amenable to telehealth, but there are a lot of situations where telehealth can be really beneficial, and I think you have to rely on your clinician and on your own judgment as a patient to decide when and if it's appropriate to do telehealth. That being said, it is still a great adjunct to the current availability for our patients and accessibility to healthcare.
And I would like to add in too, especially for those older patients that have trouble getting transportation, or really for anybody. And then also, we do have a number of patients when the weather is bad that have to cancel their visits but haven't been seen for quite some time. So in that sense, giving those telehealth visits, especially for people and patients that are known, is very helpful.
Yeah, no more snow days for having to close down the clinics on a really busy snow day.
Well, can I add that real quick? Don't you think, okay, though, in seeing some of those patients, even if it's just for that touch base, I know we like that physical exam, but even for that touch base, sometimes being able to see their face, you can read facial expression, you can read emotion. Yeah. A lot of that I think we're improving on and how we set up our own physical space as a physician when we do telehealth, but I think there is still the ability to connect and understand what's happening to that patient and if they're actually okay right now, or do we really need to get them in now? And so I think that it does allow us to at least touch base with a lot of our patients who might otherwise, like you said, either cancel the visit or just not come in because it's weather or transportation.
Eyeball test. You got to pass the eyeballs test.
Yep.
Okay. You're I think of you as a techie. So you're going to be my techie today. Great. Here we go. You ready? So what's coming? What's the next cool thing we're going to be doing on telemedicine?
Yeah, so we've got some really amazing things. Remote patient monitoring is kind of the big thing. So to address the question that was just asked about how do we get vitals for patients, we are looking at expanding our program to monitor patients in real time and also monitor them at moments in time with our patients at home, extending the care at home. A really good example is my father is in his 70s, and the physician has realized that it's best for him to take his blood pressure at home, not in the office. They are two different numbers. They always are two different numbers. And so what my dad does is he reports his blood pressure to his doctor over telehealth. Simple devices that you can buy at Walgreens, Walmart, CVS, but also there's new technology coming out which can see many things. There are ultrasound machines that plug into your iPhone, which we can use. That's remarkable. We are also monitoring patients on a myriad of different devices that are compact, that are almost unseen, and that we can immediately do an intervention on the spot in their home for things that we notice, hey, this doesn't look right. And before it gets even worse, we can call you, we can do an intervention remotely, even if you didn't even know something was on its way to becoming a problem. So we are looking at expanding that in here at this health system.
So I think can't wait to see like an ultrasound my brain and see why it shrivels up when I'm fighting with my wife and see what that's about. Who knew? Jess, what else we got?
Janet wants to know, is the hospital still following how hospitalized patients were exposed to COVID? She was just wondering if outside events and venues are the cause. Just do we track any of that?
You know, we do track it, and we track it. And Hawkeye, I know you and I read this stuff all the time, and it just everything I read, everything I see is outside's pretty safe.
Mm-hmm. Yeah, you know, those outside venues. It's more of from what I've seen lately. It's more just somebody in the family got it, fully unvaccinated family or household group. And then it runs through that family.
Yeah, I think that's still a really common way. You pick it up inside, and you bring it back to people you know. And then, I mean, I talked to one of my patients yesterday, and a transplant patient, and it's like, yep, one of the kids got sick, the other kid got sick, she got sick, husband got sick. I mean, everybody got sick, and so I think that's a pretty common mode of transmission. And I think that. The key is that when you go outside, there is just a dispersion that happens from all the different air currents and breaks up that breath cloud that you've seen Hawkeye and I demonstrate before in the freezer. But when you're inside, that breath cloud just kind of hangs out, and it's easier to have a longer exposure time because it's not just one breath you're worried about. It's that kind of constant exposure. The other thing we know is that cases are going down in Kansas City despite some Chiefs games now, both from preseason and the season. I don't think we're seeing outbreaks from Arrowhead Stadium, which I think there's an important teaching point there. Outdoors is good doors, indoors is bad doors. Yeah. And I think that's what we got to think about when it comes to 19. Good doors, bad doors.
Yeah.
And I just invented a new word in the English language. It happens all the time. Jess.
Cindy says, as a senator on the healthcare committee, I have heard a couple of my peers indicate that they're concerned that out-of-state physicians will encroach on Kansas's doctors' territory due to telemedicine. Do you see that to be an issue?
That is a great, great question. Let's take that on. Let's see what we are all going to say, because this is one of those things that you have to be careful with what you wish for. Because I would say the same thing. And it's funny, but it's not just states, it's actually locations. Mm-hmm. We've heard one of the fears from some of the physicians in Kansas about telemedicine who didn't like it is they're worried that physicians from KU or Advent Shining Mission or Stormont or Wichita are going to reach into the communities and start taking all the patients through telemedicine, as well as physicians from Nebraska or Oklahoma or Colorado or Mayo Clinic or New York or wherever. So what do you guys think about that? Because I think there is some legitimate concern there. I know one of our challenges has been, and you and I can talk about this in a moment too, that we have about a third of our patients come from Missouri. Mm-hmm. And so do we get licenses all in Missouri when we've been seeing them for all this time in Kansas? I mean, what do you think, Jason?
Well, yeah, so we have to follow state board of licensures. And so a physician cannot practice in a state of which they're not licensed. Now, that wasn't true during the waivers, but most of the states have moved on and put removed that particular waiver. So yeah, so if a physician has a license to practice in your state, they have an opportunity to see whatever patient they want. Now, on the flip side, a patient also has the choice of which physician they want to choose. We have our mission here is to provide care to all of Kansans, and we also have a goal in telehealth to keep care local. One of the things that's very important to understand is that when you see a doc in the box from an out-of-state, is that care isn't local, and your information isn't kept local. And so when you see a physician who is from one of those big name organizations, they aren't sharing that information back to your primary care physician. We, on the other hand, when we set up our workflows with those organizations, we make sure that we give that information back to your primary care physician, wherever it is. And so that's very important. So we cannot prevent a physician from who is outside our state from getting a license inside our state from seeing any patient in the state of Kansas. We know that a good majority of these companies are licensed in all 50 states. But what we can do is arm you with good information of how to make a good choice to see a physician and where to see your physician.
And to take another step further, let's say you just have that doc on the box encounter, it's one thing, but now let's say you need to see a specialist, you need to see other folks about it, and you've got this doc in the box you've worked with, and they may or may not have done an appropriate workup, and now you have to go see a specialist. Well, who are you going to go see as a specialist? They're still going to have to, they won't have that referral network. You don't want to go to Minnesota to go see a specialist. You don't want to go to New York. You're going to want to come to Kansas City or Wichita, Topeka, something like that, and go see the specialist. And so if you do that, it feels like that continuum of care and that record and what's been going on is better inside a Kansas entity or somebody near your location.
I couldn't say it any better. You're exactly right.
So talk to us a little bit about what that means, do you think, for our docs who are trying to see patients in both Kansas, Missouri, and other places?
Well, I think there's a couple facets to this. I think number one, I think, as Jason mentioned, we're trying to take care of our patients in the Kansas City region, in the state of Kansas, in the state of Missouri, that are local and regional for our health system. We can support them with the resources we have as a health system, whether it be primary care or specialty care. Via telehealth is a great way to reach some of those patients for all the reasons we've mentioned earlier in the broadcast. I think when you talk about then going out of state, I think it does become a little bit about choice. And sometimes it's about cost, or it's about quality, or it's about outcomes. And I think one of the things we've tried to really do with our telehealth is make sure we maintain the quality and the outcomes that we have with face-to-face visits. As we mentioned before, the care doesn't change just because you're over video. It's the support infrastructures that goes around that defines telehealth in its best. And so what we're striving for is telehealth at its best. And so whether you come from Kansas or Colorado or Arkansas or Nebraska, we want to be able to provide that level of care for you where you are when we can. Now, there also is the desire to try and keep care local, as you heard, where it is partnering with folks in those communities where certain specialties may not be available. And we can offer that specialty care and collaborate with the primary care teams in those areas or the other specialists in and around those areas to optimize care for those patients without having to have them come to Kansas City to get that care.
Yeah, and I think, Senator, you've asked a great question. We would be happy to visit with you more. You just reach out to us. I think that this is a really critical issue. And what I would say is, I don't want to be duplicitous here, because I want to be able to go and handle my patients that are in both Missouri and Kansas because they're my patients. I see them all the time. What I don't like is having physicians from way out of state develop a business model that says, I'm just going to go rate every patient, every asthma patient in the country. I don't think that's really great, because I do think that there's so much you can offer locally that you can't offer when you have someone who's hundreds and hundreds of thousands of miles away, and that I think is not necessarily helping with the continuum of care. So I think there's got to be we got to strike a balance, and I think we're going to find that balance together. But I think you've raised a great issue, and I appreciate that question. Thank you.
Melody wants to know, several insurance companies won't pay for a doctor out of network. So how would that work with telehealth?
Oh, that's another great question, Jason. What do you think?
The same boundaries we know exist with telehealth as with in-person is that we do have to look at each of our payers and work with what they who is in network and who isn't in network. Telehealth, unfortunately, doesn't break down that barrier with individual insurance companies right now.
Pamela wants to know, how do I know if a telehealth appointment would be good versus coming into the office? If I'm sick and I feel I should be seen, if I could do telehealth, I'd way rather do that than have to get out.
What do you think, Sale?
I think, truthfully, it's using your best judgment, number one. And I think if you feel like coming in puts other people at risk or makes it difficult or challenging for you, then I think being seen over telehealth absolutely makes sense. I think you can rely then on your clinician. Sometimes it's that telehealth visit is actually a bridge to additional care, whether that is seeing somebody who has a lung condition and saying, you know what, I think based on what I'm hearing from you and what I'm seeing from you, I really would love for you to get a chest X-ray and then come to see me in the office tomorrow and let's talk about a plan. Sometimes that will take place. Other times it's as simple as saying, I think you've been sick for a couple of days. I think this sounds like it's a run-of-the-mill cold. Here's what I want you to do medication-wise and medically managing this over the next couple of days. And then if you're not better, call back and either come in or we can do another telehealth visit to see what comes next.
Jess?
Okay. Yeah. Okay. A couple more questions. Carla wants to know, what about graphene oxide? Some people are trying to say that it's in the vaccine and can harm people.
That what? Graphite oxide?
Yeah, graphene oxide.
Graphene oxide.
You heard of
Can
that?
you checking that? Are you Googling that one
Yeah,
right now?
let me Google it. So again, all of the components of the vaccines are in the FDA briefs. I'll take a look at that. We know there's probably, I think, 9 for Moderna or 9 for Pfizer and 10 for Moderna or vice versa. There's very small amounts overall of any of these, but we can take a look real quick.
Okay, you're checking on that. I'm just going to say I don't think there are harmful ingredients in the vaccine. They've been given to millions and billions now of people around the world. There has never been something that has been given to so many people in such a short period of time in the history of mankind. We don't have billions of people dying from the vaccine or with all these terrible side effects. Vaccination is safe, it's long, it's old, and Hawkeye and I both got vaccinated here on the program. Whenever we're due for our boosters, we're going to do that right here on this program. And as soon as he lets me, I'm going to get the influenza vaccine here on this program. He tells me I can't do it yet, so there you go.
Yeah, we'll hold off a little bit on that. I'd just like to, we don't know how this influenza season will turn out, how impactful it will be on everybody's health, but also how long will it go. So, certainly waiting a couple more weeks is going to be
When he tells me I'm ready, let's do it. But I'm not going to show my shoulder like he does, but there's obvious reasons for that. Okay, Jess. Well, he's looking that up. And one more question.
Okay, so I'm going to combine these last 2 questions for just a quick update. Nadine wants to know what's the news about the Moderna booster, and Angela wants to know what's the word on the under 12 vaccine.
Okay, Moderna booster went to the FDA yesterday. They had a big meeting about it. They're turning that over to one of their advisory committees to help inform them. The same thing they did with the Pfizer one because they weren't sure what to say about it. I think that's really the comeuppance of it. And then it also has the CDC advisory committee will be meeting. So we'll know more. As we said earlier in the program, we're probably going to know in about 7 days, I think, within a week, what the full recommendation will be around the Pfizer booster shot. The booster shot is designed as about half the dose. I think Hawkeye and I have both said before we think the FDA is going to want to keep it simple and have it in the same time frame as Pfizer's, which would be 6 months. But I don't know that that's true. Moderna has really good antibody levels still at 6 months out. And it's because probably a lot of reasons it's dosed a little differently. It's a 4-week interval instead of 3 weeks. That does make a big difference. And it's a higher dose. So not sure what's going to happen around the question of the booster on Moderna. My gut is that you're going to end up getting one. It's going to be a half dose, and it's going to be somewhere around 6 or 8 months after your first dose. What was that follow-up question? The other one was?
On 12 and under vaccines.
Yeah, I think we expect to hear that pretty darn soon. I think that 5 to 11 year age range around the Pfizer vaccination, we're also going to learn more in the next week to 10 days. I'm expecting we're going to see an early use authorization that we're going to start giving them sometime around Thanksgiving. That's my guess.
So I don't know. I'm looking at the Pfizer FDA brief and their components. What was that?
Graphene oxide or graphite oxide.
I don't see any of.
We use it in fly rods, by the way, but I don't think I use it in.
So the other things that are in there are sucrose, sodium chloride. I mean, these are things that people ingest on a daily basis.
Yeah.
Probably in much higher quantities than are available in the vaccine. And I would venture that people, when they go to Lake of the Ozarks or go on vacations, probably ingest or take in some more harmful components.
Yeah, I'm not sure you have to go to Lake of the Ozarks for some folks to do that.
Right.
That happens on a pretty regular basis. Just, I mean, those of you who
but
smoke,
again,
I mean, holy cow.
These are all available. 9 or 10 components in each one, in each of these vaccines. They are preservative-free. Just things like potassium chloride, sucrose, sodium chloride, like salt, is in the vaccine. So it's not these other elusive or insidious type of compounds.
Hey, let me riff one more second on one thing the FDA did do yesterday. They approved a vaping cigarette, an e-cigarette for use to help wean you off of tobacco. This is not a blessing of e-cigarettes, people. Do not think that this means they're safe and effective. Do not think that they are without harm. This is just to say we're trying to get you to stop smoking. And by the way, don't get stuck on e-cigarettes either. They have a lot of health harms. Don't get carried away on that one.
I
Just
was
want to make sure we
surprised
talked
you
about
didn't
that.
bring one out here, actually.
I was
But
ready to
I
go.
think
I was
that's
ready to
more-
smoke here on the program, but I thought you and I could grab one after that.
Right. That's also more confusing messaging, you know. I think when you see the headline and then you have to really understand exactly why it was done. But
Yeah. Okay. Final thoughts. Let's start with Dr. Sale.
You know, imagine this: if we had a world without smartphones, right now, where would we be?
I'll be having
Right.
to dial in for my sports updates.
Right? And so, you know, I think a world without telehealth moving forward would be like going backwards and taking away all the smartphones, going back to your rotary phones and your pay phones. I think we've seen the benefits. We know what it can do for our patients and for our physicians and our clinical teams. We know it's a benefit. It's time to continue to expand and move forward. Find that next Apple iPhone version and move into the next phase of healthcare. So I encourage you, if you can, to connect with your state legislators who did us a great service by opening the doors to begin with at the beginning of the pandemic for telehealth and helping to keep those doors open as time moves forward.
Yeah. Just to say, that comment about calling the star is really true, because for those of you who don't remember, if you wanted a sports score, you're out of town, you couldn't find it, you couldn't listen to the local radio station, so you called the Kansas City Star. You know, about 20 minutes, they would go through all the different college scores in the country. They updated it every few hours, and then that's how you would find the Mizzou or the KU or the K-State score, because you couldn't get it any other way, right? You couldn't get those dang things. You'd be like, oh, did my team win or lose? I don't know. It's the same thing as with football or baseball. You want to go get the sports stores. By the way, just one quick thing with you. Sale's a Cardinals fan. Jeez, he's such a good guy, except got chink right there. But Dodgers, Giants, who's going to win?
Ooh,
Who do you want to win?
That's a tough one. I'd probably prefer to see the Giants win. I'm the Dodger hater as a Cardinals fan.
Yeah.
They routinely come up against us and again knocked us out this year. So probably rather see the Giants go forward.
All right. Well, I'm sorry about your Cardinals. Sort of. Okay.
Sort of.
Jason.
Grew up in
final
Minnesota,
thoughts.
Twins fan.
So
I
It's
know.
even worse, right?
Hey, these
Even in
guys
the same
cannot
conference.
come back. They were not invited.
I know. I shouldn't have said that.
Let's go Royals.
In a world where we're doing more and more digital, and I think in our personal life as well as in our public life, we are seeing some exciting things that are able to advance healthcare. So I make that comment with just the fact that we need legislation to keep up with that, and I really want to encourage you not only to call your legislator, call the Star, make an opinion in the Star, and share with them how important it is, because as we have this technology in our hand that's so powerful, we're using it in such good ways to keep ourselves safe and healthy, and it's right there in our pocket. So major requests are coming out to help us fund telehealth, help us keep this live. And as we have kind of opened up this proverbial genie out of the bottle because of COVID-19, there are many good things that have come from it, and one of them is the opportunity to see your physician anywhere at any time and get the health care you need. We're just worried about that kind of going away. So encourage anyone you can see who knows who can kind of move things along to encourage them to support telehealth parity and some of the other restrictions that we know exist that we don't want to go back into place.
Dog cock.
Yeah. So I heard from one of our
Wait. Vikings or Chiefs?
Right now, Chiefs, absolutely Chiefs.
Okay, good. Otherwise, I was going to have to ask who hired you. Okay, go ahead.
Well, the Chiefs need all the help they can get.
They do need some help right now. We're struggling.
We know
We'll be
they'll
back.
turn
We'll
it
be all right.
I just heard from one of our docs. So again, looking at boosters, Moderna will be looked at today.
Yep.
J&J tomorrow, and then next week, Pfizer for children. So that's a good thing. The other thing is continue to get vaccinated. We know that they're safe. You can see all of the components. We really ingest or take in a lot of those components every day in much larger quantities than are available in the vaccine. And just for you, Dr. Stites, we also learned something new today. One of your heroes should be going into space. So
yes!
We should all pray for Captain Kirk as well.
Live long and prosper.
I think they're a little bit delayed right now, but hopefully they will get off.
Well, this is pretty cool. Captain Kirk is going to be blasting into space, and hopefully the Enterprise will be up there to catch him if they start to fall, if there's any problem. But we'll see. They'd have to have a little bit of a time warp, but that's okay. We can pull that off. So, yeah, that's pretty darn cool. Hey, you know what? think about the old horse and buggy versus the car. You know, there was legislation introduced to stop cars from taking over from horses and buggy, right? And if you've been around long enough, you know that this story repeats itself. Every time something new breaks a few frontiers, there are those who are going to be against it. But the reality is that telemedicine is one of the most important innovations we have, and it's only going to get better and better and better. And the worst thing we could do is not take advantage of a technology that can help you stay out of the hospital, stay in touch with medicine, let us get your health information on a regular basis that allows us to stay connected with you, our patients, on a regular basis. This is really one of the most important revolutions in medicine. Let's keep it going so that when the next pandemic comes, we're even more prepared and better ready to help serve all of you. We'll be back tomorrow. Actually, that's not all true. Jess is here tomorrow. She's got some pretty cool guests. She's back with breast cancer oncologist Dr. Priyanka Sharma to talk about clinical trials during COVID. We'll meet one of her patients, Vanessa Chapman, who was only given a year to live and says a clinical trial saved her life. That's on tomorrow. We have a video recapping our frequently asked questions about telehealth that you can share. We'll be back tomorrow, 8 a.m. See you then. Telemedicine forever. Live long and prosper.
Telehealth has created the opportunity to bring care virtually to anyone, anywhere. The pandemic created a need that telehealth filled for patients who required access to medical treatment when safety protocols restricted in-person visits. Both providers and patients quickly realized the added benefits. Telehealth provided a new healthcare connection so that patients no longer needed to take time off from work, find childcare, sometimes drive great distances, or spend extra money to see a doctor face-to-face. Patients only needed access to a phone or computer to receive great care at home. Did you know that telehealth supports a wide range of healthcare? From seeing patients with a simple rash to patients with complex heart disease. Telehealth truly delivers care to people who otherwise may not have been able to see a doctor. So smaller communities typically do not have the specialty care larger cities typically see. Telehealth brings specialty care to all at a time and place that is most convenient for both patients and providers. Last October, a provider in our health system saw a farmer who was in their tractor harvesting their crop. The farmer stopped the tractor, had their visit with the doctor from the cab of their tractor, and went right back to work. If telehealth wasn't an option for that farmer, he would have missed a whole day of harvesting. The farmer shared with us if it had not been for this technology, he would have canceled his appointment to get his crops in before the weather changed. As you know, high-speed internet broadband is important for countless reasons, including getting the best connection for telehealth video appointments. Did you know that in the fall of 2020, Governor Kelly signed an executive order establishing the Office of Broadband Development? The order designated nearly $50 million to the Connectivity Emergency Response Grant Fund. The money was for the installation of broadband cable lines to communities lacking in high-speed internet across Kansas. Now, more than ever, Kansans have the internet access they need for telehealth because of the investments in broadband made possible by your state legislators. Parity simply means the ability for providers to receive the same amount of money for a telehealth visit as they do when seeing patients face-to-face. This is incredibly important. As many of you may know, we currently do not have permanent parity in the state of Kansas. This is incredibly important to sustain telehealth as we use it now to benefit patients. Before the rules around parity were temporarily changed, we typically saw about 100 patients via telehealth a month. When the COVID-19 pandemic hit, swift action by state legislators led to relaxed telehealth rules and new pay parity for telehealth visits. Patient demand for telehealth soared to over 1,400 visits a day. Today, we still see anywhere from 600 to 700 patients daily via telehealth. Patients and providers have come to know and trust telehealth. Providers cannot continue to offer these services if payment isn't in line with the cost of the service. Clinic staff are still doing intake for patients. Providers are still spending quality time with their patients. Nurses are still providing care coordination and patient education. Just as with face-to-face care, the cost of patient care still exists with each telehealth visit. Ending or minimizing pay parity for telehealth services jeopardizes this avenue of care for everyone. Rules enacted by legislators in the early days of the pandemic allow for current temporary telehealth changes to sunset in 2022, unless lawmakers act soon. If no action is taken, the barriers to healthcare, specifically telehealth, that existed before the pandemic will return. This would be an unfortunate step backwards for providers and for patients. Patients won't enjoy the privacy and comfort of in-home visits with their physicians, or the convenience of a call from their work, even if it's from a tractor. Without continued access and parity in telehealth, our patients' continuity of care could suffer, and the ability of specialists to meet our patients where they live will be greatly reduced. Kansans will lose the kind of personalized care out-of-state online doctors won't and can't provide. Legislators can help by ensuring reimbursements for telehealth visits continue at in-person rates, and by removing geographic restrictions allowing patients to be seen when and where it is convenient for them. Legislative changes would also allow Kansas providers like me to continue to advance the future of telehealth and embrace new technologies.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.